Hi, good morning, everyone. It's Jamie McCabe from University of Washington. Bright and early on a not so sunny day here in Seattle. Thanks so much for this invitation. I apologize for the delay in getting started this morning. We're just sort of struggling with some technical issues around some cases that we wanted to show. But in any event, today's agenda is to talk a little bit about valvular heart disease in patients with cancer or in cancer survivors. And it's actually a really big topic. Though interestingly, it's more anecdote than data. And I think probably that's everyone's lived experience as well. So I think it's an opportunity to discuss how these two disease states kind of can combine and merge, how they can be how a multidisciplinary team can really affect important change for patients. Though I have to recognize that a lot of this is simply experience or anecdote. So let's jump into the slides here. As a background, cancer and heart disease, we just want to talk a little bit about sort of how they go together, what the current state of affairs is. We had two cases laid out, and I do apologize, we're struggling a little bit to get those working right now. I've got two amazing fellows, Raf Harari, who will be a attending physician in the NYU system next year doing structural heart work, and Logan Vincent, who will be staying with us to do an advanced structural heart year with me today, and they're working diligently to get those cases in a showable fashion. There's been some computer corruption issues, so they're working in the background. We're going to keep going here, and then we'll be able to show those cases, and then ultimately get to some conclusions and wrap up. So, background. These are essentially self-evident sort of bullet points, but just to set the stage a little bit, cardiovascular disease and cancer, very common, obviously. Cardiovascular disease is an important cause of morbidity in patients with cancer. Cancer treatment, as everybody on this Zoom knows very well, is associated with potential cardiac complications. And I'd like to think that in the next handful of minutes, we're going to show that transcatheter therapies offer safe and effective alternatives to surgical approaches for patients with cancer and structural heart disease. It will take a minute because I think it's important to define what structural heart disease is. At its most rudimentary form, I guess you could say it's any non-coronary intervention using a catheter-based approach, but and that would encompass things like left atrial appendage occlusion, for example, and patent foraminal valley closure, things along those lines. But really, for the purposes of this talk, we're going to focus on valvular heart disease and transcatheter therapies for those valvular disease states. So really, the best known and the ones where we're going to focus on: aortic stenosis, mitral regurgitation. If you wanted to throw in the mix tricuspid regurgitation, perhaps mitral stenosis, aortic regurg. Obviously, those all play a role, and hard to touch on all of them at the same time. But for the purposes of our talk today, we're really going to focus on those two, aortic stenosis and mitral regurg, as structural heart disease therapy, since that's what most centers will have available to them for treatment. So first off, how do cancer and valvular heart disease go together? Pretty simple, really. It's an aging population. Obviously, the prevalence of both disease states go up dramatically as the population ages, and therefore it's a very highly overlapped Venn diagram. And I think we've all had that experience of seeing elderly patients who might have aortic stenosis, who might have a cancer, and you'll start to think, well, how are we going to address this sort of patient? And that's the milieu, that's the setting that we're dealing with here today. I think it is important to just show a little bit of data around TAVR, because it has been a bit of an experiment in growing the pie, so to speak, and that speaks to who these patients are who are getting structural heart disease therapies. So these data here that show early days of transcatheter aortic valve replacement utilization, 2012 to 15, as you see. TAVR is in red, surgical valve replacement, both with tissue valves and mechanical valves, are respectively in blue and orange. And the point to make here is that while TAVR was growing enormously in sorry.
Yes. Sorry, Jamie. Can you share your screen again?
Yeah.
I was trying to get Rolf on as a panelist. So sorry about that.
No
and I
problem.
got him on, so we can share his screen later.
That's terrific. Thank you very much. I appreciate that. So as TAVR was growing almost exponentially in those early days over the last decade, what we noticed was that surgical aortic valve replacement volumes didn't drop off, right? So it wasn't that we were cutting the pie in a different way around a series of patients who were young and well, for example. What TAVR did was it sort of provided a lot of education around disease state, and it incorporated or brought into the fold a lot of patients who weren't otherwise being treated before. And that's why, theoretically, that's why surgical volumes didn't drop off. And so who are these patients who had been sitting there with aortic stenosis for years or for some period of time, but weren't getting surgery in the first place? Well, they're the older patients, the more frail patients, perhaps they're patients with cancers, for example, or other comorbid conditions. And I think everybody has seen that over the last number of years. So we are, in the TAVR world, we've been dealing with patients with highly complex comorbidities, frailty, and advanced age for quite a while. And this graph is probably not completely up to date because over sort of more recent years, surgical volumes have started to dip as TAVR has encroached on the low-risk population. But the point is that early on, certainly, we're really dealing with much higher risk populations, much more complex patients. And I think these are exactly the kind of patients that we're thinking about when it comes to oncology and structural heart disease overlap. So let's keep going here. Now, I told you that this is mostly anecdote, and I wanted to give you just one little bit of data to, in some ways, prove the point. There is one meta-analysis that I could find looking at TAVR and active cancer. It was published last year in Open Heart and incorporated 3 studies total and 368 patients with cancer. And essentially what it showed was that the 30-day outcomes, patients with or without cancer, were no different. 1-year all-cause mortality was almost doubled, the relative risk ratio 1.7 for patients with cancer, which was all driven by cancer staging. So early cancer staging patients had very reasonable or sort of unchanged 1-year mortality rates relative to non-cancer patients, but as you start to get up towards metastatic cancer or higher sort of staging of cancer, those patients did tend to do worse. That's kind of it. I mean, there's a little bit of data on cancer and MitraClip, though it incorporated like 87 patients. I didn't even bother to include it here today. No disrespect to the authors, but I think the point is that it's a pretty data-free zone, largely because cancer patients were excluded from all the major trials. There's a huge amount of structural heart disease information out there and some very high-end trials and very large trials, but to a one, they have excluded cancer as a enrollment criteria. So we just don't have a great handle on what to do with these patients. All right. There are a lot of ways that structural heart disease and cancer can overlap. And I just picked a few that come up in our everyday practice. I thought this would be an opportunity to just talk about them a little bit and make sure that we had kind of don't know, piqued your interest perhaps in the different ways that that these two might relate. Let's start first with optimization, chemo and surgery. These are obviously patients who have a known malignancy and are headed towards chemotherapy or towards a surgical resection perhaps. And it comes to light that they either have severe aortic stenosis that was previously unknown or had been just followed, or perhaps they have active heart failure with mitral regurgitation, and these patients are sent sort of to a structural heart disease or a multidisciplinary valvular heart team to consider treatment options in advance of chemotherapy or in advance of surgery, where the idea is like, well, maybe it's not great to try and heal from a sternotomy while you're actively getting chemotherapy. And so those are folks where we might sort of transition to a minimally invasive structural heart approach to whatever they may have. That's one kind of mechanism. I would say in my own practice, that's probably not the major or not the most common way that that I tend to see cancer patients or are involved with the oncologist, but certainly it is one, and it does come up, and we can hopefully in a moment show an example of that. Then this one is a little, I'm pushing the boundaries here a little bit, but it's certainly been part of our practices. How do we consider minimally invasive structural heart disease therapies as a form of palliative care? Clearly, breathlessness is really uncomfortable. And when you now have a technology like, say, TAVR, that can be implanted successfully in 25 minutes or 45 minutes or an hour, or whatever it is, with really low complication rates, should that be considered part of a palliative care package for patients who have, frankly, incurable malignancy? The guidelines have said that there should be a 1-year survivability. Obviously, that's really difficult to predict all the time, and has been, I think, something that we have not put a lot of stock in here at the University of Washington, just because everybody's fallible in this regard. But then we see these patients and they say, like, I just can't, I feel miserable. I know that I'm not going to live forever, but I want that sort of different quality of life for these last few months. And if it's one night in the hospital and a very low risk procedure, is that something that I want to be involved in? So we have perhaps pushed the boundaries a little bit, maybe a little bit provocative, but we've certainly considered palliative TAVR in certain circumstances for people who are really symptomatic and otherwise, would like some different quality of life. All right. Oopsie, excuse me. Sorry about that. Let me just move my little. So then this is probably the most common way that I think structural heart disease and the oncologic practices here overlap, and that's the incidentaloma. We do 400, give or take, TAVRs a year, and see probably 50% more patients than that, or some percent more than that. All those patients are undergoing a chest, abdomen, pelvis CT in preparation and planning for a transcatheter valve replacement. The number of kind of incidentally found tumors, masses, things is really quite large. I mean, you imagine the average age of these patients is somewhere in their 80s, and getting that many CT scans, you're going to find a fair number of things. So these are patients who are coming to attention because of their heart disease and are looking for treatment in that regard. And then, whoops, we find a renal mass, or we find some other tumor, a lung nodule, for example. And then it becomes, well, what are we going to do with that information? Who are they going to see? How are we going to stage them next? If it is a high likelihood of cancer, does that mean we're going to sort of pull back and not offer therapy? Or does that mean we need to offer the structural heart therapy like the TAVR or the MitraClip up front to make any potential, therapies for their cancer easier down the road, and to kind of take that active heart failure syndrome out of the picture. So that, I think, is, for at least in my practice, the most common way that I see the overlap happening. Okay, and then and then there is the consequences of cancer therapy. So these are patients who have had cancer, didn't have structural heart disease or cardiovascular disease in the first place, but then, as this group well knows, you go through, mantle cell radiation, or you go through something, and all of a sudden you sort of maybe develop new heart disease, or you develop new surgical risk profile. That means that down the road, when aortic stenosis creeps up, or when something happens, maybe their surgical risk has changed in a way that would be unusual for a 65-year-old otherwise. And we'll show a case example of that in just a second as well. So those are kind of, I think, 4 big categories, or ways that structural heart disease and cancer might overlap. Worth also noting, because I do think this comes up a lot, well, how does medical therapy post-structural heart intervention affect a patient with cancer, or potential chemotherapy, or patients who are immunosuppressed, or patients who have no platelets, and so forth? There are really no hard and fast requirements at this time regarding structural heart disease patients. So post-TAVR, post-MitraClip, it's a bit dealer's choice. We're taking these as kind of individually evaluated scenarios. So a patient who might have a platelet count of 50,000, the TAVR, get the TAVR, perhaps they get no aspirin. That's okay. There's really very little data on medical therapy following structural heart disease treatments, with the exception of some data suggesting that more aggressive anticoagulation following structural heart disease therapy seems to not be beneficial unless you have evidence of some kind of rare things like hypoattenuated thickening or subthickening valvular thrombosis. All right, I want to get into some cases here. Let's see if we can switch over to Logan Vincent, one of our incredible fellows, and I'm going to see if I can stop sharing my screen, and we're going to get her screen on here if we can. Sorry about that. While she's working, or while they're working behind the scenes, are there any questions from the panel or anything that we can address at this moment?
Steve, I don't know if I can be heard. Can I be heard?
Yep.
Yeah, this is Dan Linehan at WashU in St. Louis. Thank you so much. Thank you so much for your presentation. And I'm sorry I can't see the screen for some technical reason. So that's probably related to my computer, but I have been listening. I was just curious, there have been a few publications, as you mentioned, one actually, about patients with cancer that are undergoing TAVR, and there was 1 or 2 publications in JACC Cardio-Oncology this past year where we were really trying to understand which of the patients that have, significant AS, are actually acceptable, even if they have, a cancer that may be active. So that's question 1. And then question 2 is, do you guys encounter a higher than expected rate of amyloidosis as a secondary condition in your patients? And
yeah.
Sorry if I couldn't see the slide. Sorry about that.
No, those are fantastic points to queue up. So the amyloidosis one is really interesting, and I will say that Generally speaking, for people with advanced cardiac amyloidosis, I don't think that is one scenario where I think it's fair to be pretty discouraged, and dangling the carrot of TAVR as a mechanism to feel better, to breathe better, is perhaps overselling what we can realistically do. I have treated a few patients with cardiac amyloid who were relatively early. They had biopsy diagnosed cardiac amyloid, but were relatively early in the process, didn't have a ton of diastolic dysfunction yet. And so we have sort of addressed some of those patients, but certainly late stage cardiac amyloid with a lot of diastolic dysfunction, it's really hard to make them feel better. In terms of sort of which targeted patients with active cancers are best for structural heart disease therapy, I guess I would almost frame it slightly differently, and say that to date, I am not aware of any data suggesting that that patients do worse interprocedurally, or that meta-analysis did suggest that perhaps there was higher rates of pacemaker in cancer patients than in non-cancer patients, which I can't totally explain. But short of that, I think as long as the procedural risk remains really low, and where you're talking about just a 1% or a couple of percent stroke risk and a highly successful valve replacement, it's hard to we're not dealing with like a precious commodity. I mean, there's healthcare expenditure, but it's not like we're giving people organs. And on some level, I think if you can, if you have a system where you can get people in and out, they can breathe better, you can open up the possibility of more, aggressive chemo or, future surgical options that they didn't have before. We really haven't balked that much. I think patients who there is an important aspect to incorporating palliative care, geriatrics, oncologists in the process of the sort of heart team, and sort of thinking through what's best on an individual basis. But I don't, we've never said, well, you're a stage 3, this, that, or the other. We just don't treat that. That really hasn't sort of come up for us, simply because it's really hard to paint an accurate picture of how people are going to do in the long run, and we think the risk profile of treatment has generally been good. Now, sometimes
I think I totally hear what you're saying, because this is exactly what we struggle with. But so I mean, all of the points that you made are totally on the money. The real sticky points, in my view, so amyloidosis is one, and that's definitely a challenging point of view. In the case of hematologic malignancies where their platelet count may be reduced, that's a difficult situation for sure. And then the other is, we sort of go through this calculation when you're talking about whether to put a defibrillator in for heart failure or whatever, where generally speaking you would like to have at least a 1-year mortality expected, greater than 1 year mortality from the cancer condition before you even start considering a device. And I suppose TAVR is kind of along that line too. But it's so hard in this day and age to where do you draw the line? Because if you ask an oncologist or a hematologist in particular, what's the outcome of their cancer, they say, oh, well, I just gave them chemo, so they're cured. And it's hard to put a time stamp on expected mortality. It's hard to figure that out.
Yeah, this is Josh Mitchell at WashU, and I just like to echo that point because I saw a really great case in clinic just 2 weeks ago who was diagnosed with stage 4 lung cancer, small cell lung cancer, and I saw her about a year ago with severe AS, and the discussion was that her prognosis would limit the ability for TAVR. And then I saw her in clinic essentially 1 year later, and she's still doing fine. She's stable on checkpoint inhibitor therapy, and now we're sending her for TAVR. And just with the newer therapies, it's just really impossible to predict most of the time what the prognosis will be for the cancer.
You want to turn it on?
Yeah, so I would just like to, this is Cal Bush in Dayton, Ohio. I'd like to make an anecdotal comment. My interest in cardio-oncology was pretty much driven by the finding of significant valvular heart disease in a patient whose diagnosis of Hodgkin's at a young age was never really entertained as she was working through problems with recurrent heart failure. I was asked to see her to do a transesophageal echo, and she had tremendous calcification of the mitral valve. And I had made a comment that I did not believe that this is related to rheumatic disease, which she was being treated for. And as I delved back into her history, it was pretty incredible the amount of radiation that she had, in addition to the anthracyclines that she had had. And she subsequently went on to have mitral valve replacement. She had mild to moderate aortic stenosis. She had pericardial disease. She had mild coronary artery disease. She had moderate carotid disease, and subsequently developed cancer of the breast as well while she was under my care. So it was just a tremendous learning experience and really got me interested. This was back in late 2012, early 2013, really got me interested in cardio-oncology. So just interesting. If you don't pay attention to the history, you'll never learn anything from the patient. And the medical record really did not give a fair appraisal of what was going on. So just a comment.
This is Carrie Skirka from Franciscan Health in Indianapolis. I just wanted to share that I got to hug one of our TAVR patients yesterday who had critical AS when we started treatment. And I believe she's almost a year and a half out. And she was just moving just right, doing really well. She's 80 some years old. And we have a few like that already that have received TAVR at our practice. And I'm glad to hear that you are presenting this today.
This is Joe Parker from Philadelphia. I just wanted to extend the discussion that Dan raised about amyloid. And there was a recent article in JACC, I think in January, about the coincidence of amyloid in patients undergoing TAVR, and it's like 12% of people who never even thought of having amyloid. So I think in the elderly population getting TAVR, we should at least begin to think about concurrent amyloid.
Jamie,
Hi, this
your
is
microphone is muted, Jamie.
hi. This is Robert Copeland Halpern from Northwell Cardio-Oncology, and I don't want to delay the rest of the presentations, but I was hoping to hear a little bit more about what the sort of perceived barriers are for structural interventions in patients with cancer. Is it, reimbursement or CMS documentation and things like that that often prevents people from doing these procedures? Because, so often, the prognosis of the cancer really depends on the patient's ability to get treated. And, severe AS and symptomatic valvular disease can often limit the patient's ability to get the chemotherapy, which then may limit their prognosis on that basis, which is one of the sort of frustrations that I've encountered, as I'm sure many others have. So I was just hoping I could hear more about, what the barriers are. Is it documentation with respect to reimbursement? Is it, education? How, just from your perspectives, I would appreciate it. Thank you.
Yeah. Do you believe there are barriers? Because I guess I would have said that. Sorry about the reverb there. I guess I would have said that I think the barriers are largely within institutional heart teams, and whether or not they sort of have the appetite to take on these patients. I haven't noticed personally any barriers in terms of reimbursement or documentation or so forth. You know, I suppose I will say that as public reporting continues to grow around cardiovascular procedures and grow into the structural heart disease space, I do think there is concern about sort of mortality rates, and centers want to advertise around, you know, the idea that 100% survival at 1 year, or whatever it might be that you might, you know, put in a radio ad or a billboard. So perhaps there's that. I mean, it is entirely possible that people are very operators want to be careful around their outcomes, but I have not personally noted any pushback on the part of payers or insurers or anything along those lines. So I suppose all politics are local, and you know, you never know exactly how things are going on the ground at any particular one place, but it's not been our experience, at least in Seattle, that we've had any trouble moving these patients along, and for all the reasons that were mentioned by the commenter, we have been pretty aggressive about moving forward, and in fact try and prioritize these patients so that they can take that one thing off the table and make the treatment scenarios that much less complicated. At least that's how I think we're moving. So with that, I want to get into a couple of case examples just to sort of wet your whistle. And we have Dr. Logan Vincent here, who's our one of our outstanding interventional fellows, and she's in the room with me, so I'm going to mute and let her take over.
Okay. Good morning, everyone. I have the pleasure. Why am I echoing?
No, that was me.
Oh, it's you. Okay. Of providing an example of how transcatheter valve interventions can benefit patients following radiation therapy that they may have had in the past. And so we'll get right into the case and some of what this allows us to review. We took care of a 67-year-old woman who had a history of childhood lymphoma requiring mantle cell radiation. And she presented in her late 60s with symptomatic multi-valve disease. Specifically in terms of her cardiac history, she'd been noted to have a PFO earlier in life and had a PFO occluder placed. She had what was thought to be severe tricuspid regurgitation, mild mitral stenosis and severe mitral regurgitation, as well as likely severe aortic stenosis with some mild regurgitation. In terms of her other medical history, notable mostly for the Hodgkin lymphoma, as well as hypothyroidism, hyperlipidemia, and depression. In the context of her symptomatic valve disease, she was referred for surgical management at an outside facility of the plan was to address her mitral and aortic valves during her planned surgery. Prior to the surgery, in terms of imaging, they had obtained a chest x-ray to evaluate kind of surgical entry and what they might be getting into. You see that this was actually the chest x-ray on initial presentation to our hospital, but presumably looked similar to what she had the month prior, just without the sternotomy wires. There was not heavy aortic calcification noted initially, but I think in retrospect, looking back at it, we can note some significant calcification here on chest radiograph. She was brought to the operating room at the outside facility for her valve surgery. Following sternotomy, the surgeon was able to directly visualize her ascending aorta and palpate the aorta, looking for an appropriate place for cross clamp, and appreciated significant aortic calcification described as a porcelain aorta, and did not feel like there was a safe space to cross clamp the aorta, and that she actually would have required a full ascending aortic replacement. In this context, given her other comorbidities and the situation, her case was aborted. She, did the immediate postoperative recovery from the sternotomy itself, and then was referred to the University of Washington for consideration of transcatheter options. I wanted to just show some of her initial transthoracic images that were obtained prior to her presenting with us. Brief clips, but I think what you can appreciate is heavy mitral annular calcification, as well as heavy calcification in the region of the aortic valve annulus as well. The Doppler flow patterns to show her mitral inflow as well as her aortic valve gradients, which the velocities are well above 4 meters a second, consistent with severe aortic stenosis. When she arrived for evaluation with us, we wanted to better understand kind of these multiple valve issues that we knew that she had. And so we obtained a transesophageal echo. I apologize that the clips aren't looping, but what you can appreciate here is significant mitral regurgitation, at least moderate here. Oh, good grief. And heavily calcified and stenotic aortic valve that is not opening well, and there is mild aortic regurgitation. I think, one of the things that this brings to mind when we are talking about interventions in the transcatheter space is that, unlike surgery, where if you're going to go in and do a sternotomy, you want to take care of all of the valve lesions kind of in one go so that you can avoid chest reentry. When we are working in the transcatheter space, you have the option to approach these lesions serially, given the minimally invasive nature of the procedure. And I think our approach has generally been to approach, try and solve the outflow problem first. And we felt like if we could fix her aortic stenosis, we may actually improve her mitral regurgitation and spare her subsequent interventions. And if not, could go back later. A big part of planning for us in the TAVR space is a CTA of the chest, abdomen, and pelvis. One of the reasons this is very important is to evaluate for things like aortic calcification. So that we kind of know what we're getting into. And when we are working with surgeons to make decisions, this is very useful in thinking about what a surgical bailout option might be. You can see here on the CTA, we can appreciate heavy calcification in her aortic arch in particular, and down around her aortic valve annulus. So, although this was not appreciated prior to her initial sternotomy, I think it raises the question of what sorts of chest imaging we should be getting prior to considering, particularly patients who've had chest radiation when we're considering them for surgical versus transcatheter valve interventions. Certainly at our institution, it's changed our practice and the way we evaluate these patients with our surgical colleagues. Just for a brief introduction, the two commercially available transcatheter aortic valve options for aortic stenosis are seen here, the Edwards Sapien S3 and the Medtronic Evolut core valve. We rely most heavily on the Sapien S3 at our institution. The core valve has some specific indications for which it can be more useful, but just so that you can imagine, kind of picture what we're implanting in the aortic annulus. The other part of the pre-TAVR CT is assessing our possible femoral access sites, which is our first option. I think notable in this case, after having chest radiation, we see that her femoral vessels are essentially spared from the dense calcification that was seen within her radiation field. So just impressive there. We also will use the CT for sizing of the valve that we are going to implant, and really, given that some of the oncology patients may actually be considered for this therapy at younger ages, kind of getting the largest valve in place that we safely can becomes even more important, so that we preserve options for valve interventions in the future for these patients. So something that we really work hard to do is get the biggest valve that would be safe. So the patient was brought to the cath lab for transcatheter aortic valve replacement. Despite all of our efforts to ease the technology here, these videos are not going to play, but essentially the valve was successfully deployed. You can see the pre-deployment shot on the left, the post-deployment shot is on the right. The aortogram that was performed following valve deployment showed patent coronaries with good blood flow getting in there, and the valve was very well positioned. The follow-up transthoracic echo, we'll just play this image first, showed excellent aortic valve function with no significant paravalvular leak and no regurgitation. When we went back and took another look at her mitral valve, you can appreciate that her mitral regurgitation is significantly reduced compared to previous. So it did seem like fixing kind of her outflow problem really helped alleviate a good deal of her mitral regurgitation. In terms of case outcome, as you can see, she underwent what ended up being an uncomplicated transfemoral TAVR. She was seen in clinical follow-up just a month ago with her 1-month echo. She was feeling quite well. She actually is scheduled to start cardiac rehabilitation tomorrow, but she had been up and walking around and feeling well a month ago. Given that we know that she has residual mitral and tricuspid valve disease, our plan is to continue following her in the clinic serially, and should she become more symptomatic or have significant progression on echo, we would revisit the possibility of taking her back to the cath lab for minimally invasive interventions on these valves. I would just conclude this case by just kind of reviewing radiation-induced heart disease. It's a broad spectrum of manifestations: coronary disease, valvular disease, constriction, diastolic dysfunction, conduction abnormalities, but particularly with our chest radiation folks, aortic calcification can be a very significant part of planning for valve surgeries. And in studies that have been done where patients post-chest radiation all get CTs, up to 60% of these patients are found to have aortic calcification, with porcelain aorta present in about 15% of patients that receive chest radiation. So something to take very seriously and important to consider both in planning for surgical and transcatheter interventions. With that, I'm going to hand things over to Dr. Rafael Harari, who is one of our amazing structural interventional fellows, to go through our second case.
Great, thank you, Logan, and thank you everyone for this opportunity to go through cases. It's a wonderful case, and it illustrates really the impact that prior cancer therapy has on treatment and the treatment approach for cardiovascular disease. In this case, we're gonna switch gears a little bit now and talk about patients with active malignancy and how that impacts their approach to treatment in patients with cardiovascular disease and valvular heart disease. So we'll go through a case that we recently encountered, and just to mention here and to reiterate the point that we've made before, these are not the anomalies. These are patients that we're seeing on a regular basis in clinic and that get referred to us, and we encounter these patients several times a month. So it's not hard to come across these cases, and as Dr. McCabe pointed out before, as the population continues to age and survival rates go up, the relationship between cancer and heart disease will continue to progress over the years. So we have a lady who's 65 years old who has a past medical history of atrial fibrillation, severe functional mitral regurgitation, severe functional tricuspid regurgitation, who presented to an outside facility with a week of right upper quadrant pain that was exacerbated by eating. She also reported a 15-pound weight loss over the past several months, and was initially evaluated for that reason. And as we see, her physical exam on admission was pretty unremarkable. Labs were really unremarkable as well. The bilirubin was slightly elevated, as was the ALT, but nothing really sticking out on her history or presenting physical exam. Imaging, as you can see in the abdominal ultrasound, if a cardiologist can notice this, then it has to be impressive. Her gallbladder is pretty distended, the wall is pretty thickened, and there's an apparent either sludge or mass in the gallbladder that was presumptively diagnosed as acute cholecystitis and treated as such with inpatient admission and antibiotics and fluid resuscitation. The patient continued to get workup for that condition and had an abdominal CT scan that again reiterated some of these findings with gallbladder wall thickening and that mass that we can see on the abdominal CT scan measuring approximately 2.5 to 3 centimeters. There was a biopsy done of this mass that resulted as adenocarcinoma of the gallbladder, and the patient was then referred to surgical oncology for evaluation of surgical resection of this mass. Now, just to point out a couple things from the CT scan that were also pretty remarkable. As you can see, there's significant cardiomegaly with 4-chamber enlargement of both atrium, both ventricles. And on the left side of the screen, you can see the hepatic veins are severely enlarged, pointing to right-sided heart failure. In terms of her history, she did have a several month to longer history of class 3 symptoms. She'd really been deconditioned and had dyspnea that was fairly consistent with class 3, even class 4 symptoms, dyspnea at rest. Her TT, I'm not going to show the videos. The patient had not the best windows for TT, but suffice it to say she had some of the findings that we saw on CT scan with severe biatrial biventricular enlargement, normal left ventricular ejection fraction, and severe functional MR and TR. So with that said, we have to pause here for a second, and the patient was sent to our clinic for evaluation in anticipation of abdominal surgery. And the things that we consider in evaluating these patients are, number one, what's the urgency of surgery? And this comes up quite often in these patients, and this requires really a conversation between multiple different specialties, including cardiology, cardio-oncology, cardiac surgery, anesthesia, and so on and so forth. And in terms of their cardiovascular risk for non-cardiac surgery, the things that normally come up and increase risk are unstable coronary syndromes, decompensated heart failure, severe symptomatic valvular disease, and symptomatic arrhythmias. And this patient, frankly, meets both of those in the sense of having decompensated heart failure with ongoing symptoms and severe symptomatic valvular disease with severe mitral regurgitation and tricuspid regurgitation. So again, the guidelines, patients with malignancy are a bit of a different population as they are often excluded from a lot of clinical trials. So the guidelines may not necessarily apply to them. So this is where individualized patient care, heart team assessment plays a significant role, as typically this patient if this case that we're presenting didn't have malignancy, she would be treated with surgical intervention, not a transcatheter approach. So in summarizing this case, we have a fairly young woman with a history of atrial fibrillation, severe MR, TR, who's recently diagnosed with gallbladder cancer, requires surgery, and has decompensated heart failure with class 3, class 4 symptoms. And that leaves us with 3 options, and this is what we've discussed in our weekly heart team meeting that includes cardiac surgery, cardiology, anesthesia, and so on and so forth. And of course, the medical team that referred the patient. So the options were to medically optimize the patient and move forward with surgery, understanding that there's a risk for decompensated heart failure in the preoperative period and morbidity and mortality associated with that. The second option would be to have surgery for that mitral valve and tricuspid valve and forego abdominal surgery for some time until that patient recovers, and the duration of that is a question mark. We've seen patients recover quite fast, and patients have complications and have a delayed recovery from cardiac surgery. And the third option, which we moved forward with, was the transcatheter approach for mitral valve regurgitation. So just quickly, mitral valve regurgitation is related to anything that affects 4 of the 4 different elements of the mitral valve: the annulus, the leaflets, the cords, and the muscles. We all are familiar with this. Different etiologies or classification of MR are primary, where there's a pathology of the mitral valve, such as a flail leaflet or perforation, and secondary, which is related to functional, which is also called functional mitral regurgitation. That's related to abnormalities with the morphology of the left ventricle and the left atrium. This is a rather newly developing theme in the world of mitral and tricuspid regurgitation. This is atrial functional MR, and it's a multifactorial etiology that's related to the pathology and pathophysiology of the mitral annulus and atriogenic leaflet tethering, as well as pathologic dysfunction of the leaflets that cannot keep up with this type of regurgitation in terms of remodeling compared to other types of mitral regurgitation. So just quickly going through the history of mitral regurgitation, it all began with the Alfieri stitch. That was the idea that planted the seed for this therapy, and it evolved in the late 90s, early 2000s as the eValve system, which then became the mitral clip system that we're familiar with these days, and that's the catheter system that we use in the 4 different flavors of clips that we have with the new system, with 4 different combinations of length and width of these clips, and that gives us a lot more options to treat different pathologies in patients with MR. The rationale for use is you can create a tissue bridge that limits annular dilation, as well as improve leaflet coaptation and reduce MR, and also limit theoretically LV dilation by restraining the LV free walls. And you can see over time the tissue endothelializes in the mitral clip and becomes one with the device that's implanted. This I'll skip. These are the grippers that essentially dig into the deflet as the clip is detached and allow it to stay attached to the leaflets after deployment. So the mitral clip procedure, we'll move a little bit quickly through the intro slides here for the procedure. It's transseptal puncture through venous access and delivery system through the right atrium into the left atrium. And under fluoroscopy and TE guidance, we position the clip in the right position to treat the patient's pathology. So this is our patient's TE from the day of the procedure. Again, you see what we saw before, a severely dilated left atrium, right atrium, a normal function of the left ventricle, and dilation of the mitral annulus with leaflet tethering, resulting in a non-coaptation gap of the mitral valve, which results in severe mitral regurgitation. This is a composite of 3D TE provided by Dr. Mackinson from the case. And again, this is the surgeon's view from the left atrium into the left ventricle, and you can see the anterior leaflet here. And it's evident that there's a non-coaptation gap that essentially extends from commissure to commissure. This image is the same 3D with color, and you see there's severe central mitral regurgitation spanning almost from commissure to commissure. And again, 3D, a couple more pictures showing the pathology and the regurgitant jet here. So, in terms of her baseline hemodynamics, we see the ERO of 0.65 and the vena contracta area of almost 1.4, with left atrial pressure of high 20s and V waves to 35, and reversal flow in the pulmonary veins. Her procedure was performed with 2 different clips, an XTW and an NTW, and I urge you to resist the impulse to grade the MR just by color alone. This is perhaps not the most elegant case we've seen, but again, in patients who have commissure to commissure mitral regurgitation, it's impossible to eliminate all of that regurgitant jet. That being said, this is the final result. There is residual mild to moderate MR. That being said, with evaluation of the hemodynamics, we see the pulmonary venous flow has normalized, and the left atrial pressure is about 10 with V waves to 14 from 35. And this is the TT the day after the mitral clip with residual mild to moderate MR. So the patient is undergoing evaluation by surgical oncology today, in fact, and will be having surgery for her gallbladder malignancy in the coming weeks. And hopefully this procedure will provide her a bit of a safety net in terms of reducing the risk for adverse cardiovascular outcomes related to her abdominal surgery. So to conclude, the pathophysiology of MR is complex and involves the 4 different elements that make up the mitral valve apparatus. There is really a lot of positive evidence to guide perioperative management of patients with active malignancy and severe valvular disease. And transcatheter edge-to-edge repair of the mitral valve and tricuspid valve are well-established procedures that offer an excellent safety and efficacy profile. And we anticipate we'll see these procedures being done a bit more frequently in this particular population for the reasons that we've discussed. So with that, I'll open it up for questions from the panel or any comments from any of the viewers.
Great. Thank you for such an awesome case. Usually, if you feel that the tricuspid valve is significant, then you have to address that somehow, and typically that may tip you over towards surgical intervention. How did you see that decision in this case?
Yeah, well, I feel that one for a second. This is unfortunately a woman who has really extensive cardiovascular disease and had been referred for surgery, I believe, a number of years ago, and then sort of kind of kicked the can down the road. I think that most of her symptoms when we saw her in clinic were left-sided heart failure, left-sided congestion in terms of PND and orthopnea, and so forth, and sort of a dyspnea on exertion. She clearly has abdominal bloating. She clearly has tricuspid symptoms, though tricuspid symptoms in general are somewhat more difficult to sort of parse out. But it was our feeling that in terms of just getting her as quickly as possible to a potential surgery for her adenoma, we wanted to address her left-sided congestion, which seemed like one of the predominant features of how she was doing. And I think, we're really in uncharted waters when it comes to clip to facilitate non-cardiovascular surgery in cancer patients, and certainly in uncharted waters when it comes to, say, clipping the tricuspid valve in advance of non-cardiac surgery. So while we do a lot of tricuspid valve clip,
I wasn't trying to.
Didn't feel like something we needed to do in advance of her abdominal surgery. Clearly, in a non-cancer scenario, in a 66-year-old woman, these valves would be better addressed with annuloplasty and repair, surgical repair. But that just wasn't felt to be an option for her at this time. She's pretty frail, she's really deconditioned and very symptomatic, and needs this other surgery. So we left it alone for now, and I sort of talked to her primary cardiologist and said we'd be happy to address her tricuspid valve at a later date once sort of her bigger troubles have been addressed.
No, I mean, I agree 100% with that. I was just wanted to hear you talk about it.
Yeah. These are, every one of these patients is just, you feel like every day is a school day, unfortunately, because there's very few well-trodden paths at this point. We have, I think, I don't know what the time frame is for this. It looks like we've gone over a little bit. I welcome any other suggestions or comments, but first I wanted to just thank Dr. Vincent and Dr. Harari for their great case presentations. I wanted to thank the organizers of this session for inviting us. It's been a real pleasure, and certainly fun to share some of our stories. Hopefully in the future we will have better terra firma in terms of data and to stand on. But at the moment, like you say in structural heart disease, sometimes we're kind of making the news, not reading the news. So we're constantly trying to figure it out, and thankful for the partnership with everyone involved as we stumble our way forward sometimes.
Super. Now this is really and thank you for sharing.
Yeah, thank you so much for your presentation. We really appreciate it, and thank you everyone for joining today. Hopefully we'll join us next week. Take care.
Bye-bye.
Thank you. Goodbye.
Thank you.